Welcome to The Explainer. We are jumping right into things today because we're tackling one of the absolute most maddening scenarios you can face in clinical practice. We're talking about chronic mucosal conditions. Whether that's in the mouth, the bladder, or the GI tract, these are the conditions that just seemingly refuse to heal. You know the exact scenario, right? You've diagnosed the issue, you prescribe the absolute gold standard therapy, you've set expectations with your patient, but months later, they are still suffering. So today, we're going to break down exactly how to evaluate a clinical non-responder who reports absolutely no subjective improvement 12 weeks post-treatment, and we'll empower you with a really clear, data-driven approach to get over this hurdle.
Okay, picture this. Your patient is right at the 12-week mark of their treatment plan. That is 3 full months of continuous therapy, and yet they're sitting across from you in your office and they report zero subjective relief. The burning is still there, the dryness feels just as agonizing, the pain literally hasn't budged. It's incredibly frustrating for them, and honestly, it can be totally baffling for us as clinicians. So what do we actually do when we hit this wall?
Well, first, we need to formally define what we're actually dealing with here. A clinical non-responder in this specific context is a patient who lacks subjective improvement in mucosal hydration and pain after 12 weeks of initial treatment. But here is the major shift in mindset I want you to take away from this. Do not frame this 12-week mark as a clinical failure. It's not. Instead, view it as a critical, entirely expected juncture. It's a built-in pivot point that actively demands a shift in how we approach the diagnosis and the therapy moving forward.
To solve this, we've got a quick, structured roadmap for today. We'll be covering Section 1, the 12-week wall, 2, subjective versus objective healing, 3, investigating alternate etiologies, 4, quantifying mucosal tissue health, and finally, 5, escalating the treatment plan.
Let's start right off with Section 1, the 12-week wall.
You know, there's this old, pervasive adage in fields like oncology that mucosal damage like oral mucositis from chemo or radiation heals up in a nice, tidy 2 to 4 week window. We need to completely shatter that myth right now. Studies that actually map out patient-reported outcomes show that clinically significant pain and mucositis persist anywhere from 46 days to a staggering 102 days, depending on the treatment. That's pretty wild when you think about it. Tissue recovery, especially across these super delicate mucosal surfaces, is a marathon, not a sprint. So if a patient is still feeling symptoms at 12 weeks, which is 84 days, they might actually still be within a completely normal, albeit prolonged, physiological healing window.
Moving right along to Section 2, subjective versus objective healing.
Now, what's genuinely fascinating here is the complete decoupling that can happen between subjective symptoms and objective signs. A patient might report agonizing oral dryness and burning, yet when we go in and actually measure their unstimulated whole salivary flow rate, it might be completely normal, like well above the 0.1 milliliters per minute threshold that indicates true hyposalivation. The literature consistently shows that a patient's subjective sensation of dryness often does not correlate quantitatively with objective glandular output. What this means is that at 12 weeks, the tissue itself might actually be objectively functioning and healing, even if the patient's nervous system is screaming that there's severe dryness and pain.
Which brings us to Section 3, investigating alternate etiologies.
So, when symptoms persist despite our absolute best efforts, we have to pause and play detective. We need to investigate what else is in the room. A patient being treated for genitourinary syndrome of menopause or interstitial cystitis might be plateauing not because your primary therapy is failing, but because of a completely unaddressed secondary factor. Are they taking over-the-counter antihistamines that are just systemically drying them out? Do they have an opportunistic candida infection masking as primary mucosal pain? What about undiagnosed systemic diseases like diabetes or a thyroid issue? Or could a simple vitamin B12, iron, or vitamin D deficiency be directly triggering their burning mouth syndrome? If we don't actively look for these confounders at that 12-week mark, we are going to end up escalating therapies for absolutely no reason.
All right, let's jump into Section 4, quantifying mucosal tissue health.
To make sure we aren't getting entirely derailed by a patient's subjective pain diary, we absolutely must rely on validated clinical frameworks to visually and numerically score the tissue. Let's look at the Chalicombe scale for oral dryness as an example. We are looking for really specific physical signs. Does the dental mirror stick to the buccal mucosa? Is there saliva frothy? Is there a noticeable loss of papillae on the tongue?
A score of 1 to 3 means mild dryness. We just need simple monitoring. But if that score jumps up to a 7 through 10, that's severe, and it's a massive red flag, signaling us to immediately exclude systemic autoimmune issues like Sjogren's syndrome. Frameworks like this, or the TFOS-DEWS-I for dry eye, they force us to treat the objective reality of the mucosa, not just the feeling.
And this brilliantly illustrates exactly what that objective healing looks like on a cellular level. This data is from a study on Sjogren's syndrome treatments, specifically showing a parotid gland biopsy stained for CD45 at the 12-week mark. If you look at the rituximab treatment group over on the right, you can see a significant decrease in the relative area of inflammatory cellular infiltrates compared to their baseline. The inflammation is literally objectively clearing right out of the tissue. Yet in so many of these cases, patients might still report subjective dryness or discomfort at this exact same 12-week check-in. The tissue is healing. The subjective perception is just lagging way behind the cellular reality.
Finally, we reach Section 5, Escalating the Treatment Plan.
So escalation is not about just throwing heavier drugs at the wall and hoping they stick. It is a highly calculated, tiered pathway. Step 1, before you change a single thing, rigorously reevaluate adherence. Is the patient actually taking the medication, or are there financial or educational barriers getting in the way? Step 2, if their adherence is rock solid and you've ruled out those confounders we talked about, then we step up to targeted, higher concentration prescription therapies. And step 3, if the objective signs still won't budge, that's when we initiate multidisciplinary referrals, bringing in rheumatologists, pain management specialists, or neurologists.
Let's look at how this treat-to-target escalation works in actual practice across different mucosal surfaces. If a patient with bladder pain syndrome doesn't respond to standard bladder instillations like cystostat after several weeks, you don't just give up. You escalate to Ialural, which contains a 20 times higher concentration of hyaluronic acid. For genitourinary syndrome of menopause, if over-the-counter moisturizers are failing, you step up to prescription localized estrogen creams or rings to directly restore that tissue elasticity. For burning mouth syndrome, when topicals fail, we shift gears to target the nervous system with neuropathic pain meds like clonazepam. And for ulcerative colitis, we move towards advanced biologics. The core principle is exactly the same everywhere. Measure objectively, escalate logically.
I want to wrap up by leaving you with this really powerful concept drawn from the management of ulcerative colitis, specifically regarding the Mayo endoscopic score. It states, extensive evidence has underlined the importance of mucosal healing as a treatment aim, when 0 is better. True clinical remission isn't just about a patient sitting there and telling you they feel a bit better today. It is about achieving absolute, objective, microscopic tissue healing. So as we manage this 12-week wall, it really begs a fascinating question. If a patient's subjective pain outlasts their cellular inflammation, are we actually still treating a mucosal disease? Or have we crossed over into treating a localized neuropathy? Keep pushing for that objective data. Keep asking the hard questions, and I promise you will get your patients through that wall. Thanks so much for joining me on this explainer, and we will see you next time.